And now we are going to move on to our second group of presenters. So we will move the slides to that, and we will switch off. So we will begin our second group of presenters. This is going to be posters numbers 6 through 10. And Caitlin and Drs. Farrell and Chung, I believe they're both on this.
Yep. Dr. Chung may or may not be popping in and out. She's got battling commitments, but I'm here.
Perfect. All right. There you go. Sorry.
Oh, back one. There you go. All right. Thanks so much for the opportunity to share this with you all today. I'm Caitlin Farrell. I'm a pediatric emergency medicine physician at Boston Children's and a member of the Massachusetts EMSC committee. And I'm going to share with you our statewide collaboration for simulation-based pediatric education for EMS. So we know that of the 30 million patients transported by EMS annually in the United States, children represent only 7% of EMS activations. And critically ill pediatric patients are a low-frequency, high-stakes event. Previous work has demonstrated barriers to quality pre-hospital pediatric care, including limited initial training, infrequent exposure to and provider discomfort with pediatric cases, and challenges accessing pediatric continuing education. So at the Massachusetts EMSC, we created a multi-center collaborative between academic pediatric EDs using EMSC sponsorship. Each EMS region in the state was paired with a pediatric emergency department, and together we developed a simulation-based pediatric curriculum. We administered 5 8-hour training days offered over 6 months. Each of our simulation days included 3 cases that were driven by our needs assessment prior to designing our curriculum. So we had a twin newborn resuscitation, a seizing infant, and a toddler with impending respiratory failure due to asthma. We developed these cases with both knowledge goals as well as procedural training opportunities. And each simulation was debriefed by PEM staff with small group participation with our EMS providers. We also had didactics throughout the day and the opportunity for kind of panel discussions, family interventions as well. We performed a prospective interventional single-arm educational study with a pre-post assessment designed to evaluate the impact of the simulation curriculum in particular on pre-hospital provider knowledge and confidence. For our results, we had a total of 188 participants from 97 different towns and agencies complete both the pre and the post assessment. 58% were ALS providers, 69% were male, 32% had between 2 and 5 years of experience, and 33% had more than 15 years of experience with EMS, and 34% were from FHIR-based EMS agencies. Our results demonstrated that the mean pediatric knowledge scores increased by 9.8%, with confidence intervals there on the poster. And happily, 93% of our participants reported improved confidence caring for pediatric patients. We did some follow-up surveys, and more than half of participants who completed the follow-up survey reported they had used skills acquired during the training in their clinical practice in the subsequent 6 months. The map in the middle of the poster there is of Massachusetts. The blue outlines are our 5 EMS regions. The green stars are the training day locations. The blue crosses are the collaborating 5 hospitals, and the red dots are all of the EMS participants. So we had nice distribution across the state, which we're hoping kind of helps disseminate our efforts. The box plots there show our knowledge assessment results in the pre-training assessment, post-training assessment, and the 6-month follow-up assessment. The lines are the mean scores, and the distribution is there in the box. And we had some improvement pre and post-training, and then some sustained improvement at the 6-month follow-up step. All right. So we concluded that using EMSC partnerships to foster statewide collaboration enabled us to deliver a targeted simulation-based pediatric curriculum for pre-hospital providers throughout the state. We are pleased that participants demonstrated an improvement in knowledge and in confidence caring for pediatric patients, and our follow-up data suggests that knowledge and skills during the curriculum were able to translate into practice. My contact information is there, and I'm happy to chat and share our cases if folks are thinking about similar projects locally.
Thank you so much. Now I'd like to introduce Mark Cicero.
Hi there. Thanks for the introduction. My name is Mark Cicero. I'm a pediatric emergency physician here in New Haven, Connecticut, and I'll be presenting our poster. And the title of the poster is Modified, it's SimBox simulations and their use in the training of EMS providers. The background for this idea is that simulation often has a bit of a barrier to entry in that it may be intimidating for educators to have all the different pieces of it, including debriefing and having the concepts of simulation together. So there's an ongoing American College of Emergency Physicians initiative to take some of the concepts from a meal planning kit and apply them to simulation, meaning everything, including the scenario, the idea of a low fidelity but somewhat realistic mannequin, debriefing cues, and feedback for providers is all within the kit. And this is in the context of our ongoing pediatric emergency care coordination study. In this study, the pre-hospital providers who participated in the SimBox simulation provided some feedback as far as their net feelings of whether they promote it as a means of learning, and also go delving deeper into the various domains of the simulation and the SimBox components. So this is a cross-sectional study. We sampled data at one point, and they participated in a series of simulations. The participants were EMTs and paramedics, and they were in teams of either paramedic and EMT, or 2 EMTs. There were all the resources involved in the SimBox simulation, and the scenarios included a seizure, a child who had sepsis who advanced to having respiratory and cardiac failure, and child abuse, followed by debriefings. And participants completed an online survey in which they evaluated the content, and they said whether they agreed, somewhat agreed, or didn't agree with the content being useful for them. We also calculated net promoter scores, a means for overall endorsement of it as a means of learning. And there were a total of 121 participants, of whom 103 were paramedics. A total of 98% of them said that they agreed, at least somewhat, with being more confident in their ability to prioritize care of children after completing SimBox. And the vast majority also said that participants agreed that post-simulation debriefing with facilitators provided opportunities to self-reflect on the care provided to children. Table 1 is quite lengthy, and we don't have the time to go through it all together, but I'll draw you to a few concepts, including the ideas that overall, the debriefing was highly rated, and it's often said that we do simulation to have something to debrief about, and that overall confidence and preparation were improved. This was, by and large, in the strongly agreed column, the column that is on the left of Table 1. As far as another application of SimBox, understanding the times in which we live, the SimBox allows itself to be provided as a telesimulation or a hybrid simulation. And there's some data in Table 3 regarding participant impressions of that mode of learning. Finally, in Figure 1, we see the participant net promoter scores, and that 2/3 were strong promoters, a 9 or a 10 on a 10-point scale of SimBox as a means of learning. So in conclusion, we see SimBox as a means for overcoming some of the barriers to simulation, providing the resources that EMS educators need to provide pediatric content. And our next steps include dissemination of this SimBox and some follow-up as far as how durable the education is. Thanks for your attention.
Thank you very much. Dr. Cicero, they have asked, the QR code is not working through the poster. If you could drop the link into the chat, I can paste that in for you.
Thanks, I will.
Up next is Mark Winkler.
Hi, good afternoon. Coming through okay? Just double checking.
Yes, you're good.
Okay, thank you. Thank you for being here. Just an honor to be here with so many fine presentations and interesting topics. So today to talk about my poster project is around utilization of virtual reality for pediatric assessment. This was an effort by the Maine EMSC program to work on improving clinicians' skills around skills itself, pediatric skills. And we dove into the data statewide for the past 3 years and tried to figure out what skills folks were using and how often and in what areas, and how could we assist with that. And we originally had intended to think about utilization of physical mannequins and devices like that. And what we were surprised about was the sheer lack of interventions that often occur with pediatric transports that occur. And most of the time it was BLS measures and transport. And we quickly realized that one of the key factors that we needed to hone in on was the assessment of sick or not sick, and what was that first 5-minute decision process around. So we talked about a lot of different methods, and we researched some virtual reality options, just kind of seeing if it might be a tool we could use. And we selected Health Scholars and implemented 5 Oculus headsets. And what these headsets do is they utilize a program of up to 11 different patient scenarios of patients under the age of 5. And we found that this was our greatest need. Only about 10% of those patients in Maine had actual skills done, but 100% had assessments done. So we partnered with 3 agencies to do an in-depth quarterly review of their skills. And we bring these headsets, we leave them at the stations, and we work with the training officers from each department, and they can utilize these individually at all levels, whether they're an EMT through paramedic, new or been around forever. And it presents this infant patients in a variety of cardiopulmonary distress. They might be stable, they might have CNS difficulties, and visually it immerses the student into the appearance of work of breathing, their circulation to skin. There's a mom present in some of the scenarios, and it really immerses you with crying, and you're in a room with this child, and you verbally talk to an avatar and tell them what your assessments are, and then make a decision about what is the overall condition of this patient. So we're utilizing this for both the aspects of any level can do it, but also because providers can do this individually without anyone else around. They can socially distance away and do this in a room by themselves because it's all facilitated by the avatar. And it's also flexible time. We've all been in the position where we're going to teach a class on something and the department gets a call and we lose that opportunity. This can be done day or night whenever it's convenient for the provider. And it's self-learning. If people struggle with certain scenarios of respiratory distress, then they get more respiratory distressed patients, and they get a variety of EKGs presented to them that they assess if they're at that level. And it records all the data that they do and then comes up with a report both individually and departmentally of where gaps in performance are. And we've started to use this with developing training at the local level of where a department may have some issues. Now, we've just started this. We don't have a ton of data yet on how that's going to look aggregate across all fields, but our goal is to kind of identify where gaps are, maybe in initial education, but also Con Ed opportunities. I will say that pretty much everyone that's used this has walked away with this is amazing, whether they're a first day EMT student to 30 years in EMS. And it's a new way of looking at it. It's immersive, and it is easily transportable. It requires a Wi-Fi connection, and that's it. So it's easy to send throughout our rural aspects of Maine. We have some travel challenges here. So it's helpful. We can ship it across the state as needed. And it's a neat way to bring folks into this. And we're gathering data to see how it goes over across the next year or so. We're doing individual trainings with departments, but we're not tracking them as closely as these sample agencies. Again, the 3 EMS agencies and 1 hospital is also doing it out of their emergency department. And we've had great reviews from everybody so far using it. So happy to talk more about it, but I know we're on a limited time schedule. So.
Thank you so much, Mark. Next is Dwayne Spencer.
Good morning, or good afternoon, everybody. I apologize in advance if I go offline, but Ida has hit here, and we're under tornado watches and heavy rain. But thank you for taking the time to listen to our presentation here. I'm the program manager for the EMS for Children program in Pennsylvania, and we looked at our survey responses and how we could go about improving the EMS for Children survey responses amongst EMS agencies across the state. I began my position just before the 2020 survey, and that survey saw just under 21% of a response rate. The challenge there was information that wasn't confirmed, as well as the developing COVID pandemic. And therefore, we looked, in ahead of the 2021 survey of ways we could improve it through analyzing the contact data and improving the accuracy of it, identifying agencies that were no longer around because of mergers, closures, and staffing changes with personnel, and just make sure that we had the best information available in order to communicate the survey process out to EMS agencies. We did that with partnering up with both the Department of Health Bureau of EMS with an agency listing that they had available to them. However, one of the challenges there is we only just began identifying whether an agency was 911 or not. They're licensed the same, so it was a question under licensure application, which only occurs at a renewal every 3 years. So we're in the process of updating that accuracy for whether or not they're part of the 911 system. We also engaged our regional EMS councils, of which there are 13, and worked with them to vet the data, identify any changes that they felt were necessary, making sure we had the agencies on the list that need to be on there and ones off that did not need to be on there. So that engagement with the Department of Health Bureau of EMS and regional EMS councils was very functional to improving our results. In net, we went from a 20% response rate to over 47 in the 1 year period, and we hope to continue to increase that as we move forward into the upcoming EMS for Children assessment. We continue to validate EMS through our process to ensure that we have the right people, the right contacts, the right agencies. And we really determined that this collaborative effort by using our partners who oversee EMS agencies throughout the state really helped us. In Pennsylvania, we have over 1,000 911 agencies and over 1,200 licensed agencies. And therefore, managing that number is very difficult for a single person or single program. So that collaborative effort was very important for us to be successful. The other component we found out was the need for some regular and personalized communications, not just a once a year reach out, but a more frequently engaged process to make sure we still have the right people and they know who we are and what we are about. And like I said, we look to this to be a building block for upcoming EMS for Children surveys and not just a single effort. I added a graph here, just shows you each of the activities we did and how the result of those activities continue to improve the slope of the response rate to a point that before halfway through the survey, we were above last year, and we continued to increase our response rate with each additional reminder, whether it be from the EMS for Children program, from regional councils, or just individual asks from other stakeholders throughout the state. But overall, we believe we were very successful, and we'd like to continue with that, knowing that that personal engagement, but that collaborative effort was key to ensuring we have good success and good survey participation across the state.
Thank you. And next we'll move to Dr. Adeglace. If we could move to slide 10, thank you.
Hi, thank you so much for having me and giving us the opportunity to present on this work. Our title is Colorado State Trauma Designation and Pediatric Readiness, and this is from our EMS for Children program here in Colorado, and I'm presenting on behalf of Dr. Joint, who is working today. Just as a little bit of background, we know that prior studies from the 2013 NPRP assessment showed that there was an association with higher weighted pediatric readiness scores and outcomes, but facility trauma designation wasn't actually directly associated with pediatric readiness given controlling for pediatric patient volume. And more recently, Colorado had the opportunity to pilot the NPRP assessment. And as a result, we actually were able to get our data a little sooner than the rest of the nation. So we decided to take a look at our NPRP data to explore how trauma designation may be affiliated with with our outcomes in our NPRP assessment here. Colorado has a very robust state trauma designation program, and we thought that this would be a unique opportunity. So we conducted kind of a cross-sectional analysis of our 2020 NPRP pilot assessment here in Colorado, and we compared hospitals with and without trauma designation with regards to the 2020 weighted pediatric readiness scores. And we also specifically looked at isolated factors in pediatric care individually as well. And we stratified that across levels of trauma designation in the state. For the purposes of this analysis, we actually did remove our pediatric specific facilities. And the reason for that is we did not want to bias the results, given several of our facilities actually are higher trauma designation facilities in the state. So we specifically looked at factors such as weight in kilograms, pediatric medication dosing, the presence of a child maltreatment policy, and the radiation dosing. We looked at whether there was a pediatric death policy, pediatric pain assessment, and then finally we looked at disaster plans with pediatric considerations, since this was a new question on the 2020 survey. We did some statistical analysis to specifically look at our pediatric readiness scores. So overall, we had a 9% response rate across the state, but ultimately for this de-identified data that we looked at, based on all the eligible hospitals, we had an 83% response rate and had data on 73 hospitals at the time. We then found that removing those pediatric facilities, we had 69 that met inclusion criteria, and the annual pediatric volume between these facilities was actually only between 0 and 20 children a day. We found that level of designation was associated with the weighted pediatric readiness score, with level 1 having a score of 71, level 2 having a score of 74, level 3 having a score of 62, level 4 facilities having a score of 54, and ironically, those facilities that did not pursue trauma designation in the state had a score of 65. What we found when we looked across, and I'm sorry, the table on the poster is small, but you can see the table on the website in a little bit a bigger font as an isolated slide. What we did find was that there was a real dramatic range in many of these pediatric factors. For example, weight in kilograms was as high as 100% in the facilities that were higher levels of trauma designation, down to 50% in facilities that were trauma floor designation. The same happened across pediatric medication dosing and child maltreatment policies, just really a significantly broad range across all different factors. But one other interesting finding that we had relative to the issues around disaster planning, which I think is so key in the era of COVID, is that only 29 of our hospitals reported having a disaster plan. And among them, the majority who reported having a disaster plan did include children, but 29 of the facilities represents only 42 hospitals in the state. So trauma designation is not affiliated or associated with having a disaster plan, much less pediatric considerations. So our conclusions were that in our study, we did find that trauma designation was positively associated with the weighted pediatric readiness scores. We obviously are going to do a little bit more analysis to do a deeper dive in what our data shows us, and then use this information to start to work with our pediatric readiness program in Colorado to identify how we can help some of the trauma centers that are designated but not pediatric ready. So thank you. Happy to take any questions in the chat or by email later.
Thank you very much. We do have a couple questions. The first one is for Dr. Farrell. Was the twin birth simulation based on the needs assessment?
A little bit. So the needs assessment identified newborns as an area that folks felt very uncomfortable with, and infants in general, newborns in particular. And so we wanted to have a case around either infant or newborn care. And the group at Texas Children's with PD Steps had done a newborn resuscitation. And so we had adapted that to Massachusetts protocols. And the nice case about that is we had a mixed ALS, BLS audience at all of our sites. And so we had the first infant able to be resuscitated with kind of routine BLS care, dry suction stim, bag masking, and kind of reposition airway and have, return of vital signs. And then imminently after that, the second baby is delivered, which requires more ALS care in terms of IO placement and intubation. And so depending on the composition of our team, we had nice BLS and ALS, both learning objectives and procedures to do with debrief across both kind of genres. And then just talking about like newborn vital signs and appearance and kind of anticipating equipment you may need in transit. The kind of discussion can lend itself in a lot of different directions. So the having the newborn resuscitation as well as the seizure patient be an infant was driven by our needs assessment. And then we were lucky to have lots to learn from the group at Texas Children's who had run similar cases in the past.
Thank you. The next question goes to Mark Minkler. Using VR, are more pediatric assessment scenarios being developed by health scholars?
They may have stuff in the work behind those 11. They actually just released another program that we're a part of as well, though. And this one is, if you think about a PALS megacode scenario. So there's some different scenarios involved with those patients. I haven't fully explored that yet. It just was released very recently, but that'll be part of what we deliver as well when we go to services. So we're at 11 right now, and I think they're working on more, but I don't know from their operation end of things.
Thank you. Next question is to Dr. Farrell. Would you be willing to share the simulation-based PEDS education curriculum? Subsequent question, was it pre-recorded or live? And who presented it? And did EMS agencies and hospitals volunteer to participate, or were they voluntold mandated?
They volunteered. Happy to share the cases. I can send those out. The didactics were different at each group, and I can share the topics that we used for sure, but the simulations we're happy to share, and they come with kind of our debriefing goals as well. Happy to share those. It was all done live. So we ran it over 6 months. Each region did one almost every month for a period of 6 months. And so it was all live with PEM staff and simulation engineers running the cases live, debriefing live, and then didactics. We rotated folks through didactics to keep our simulation groups small. And so that was all live. This was 2019, obviously. So all of that was live. We recorded a few of the didactics just to share with the presenters for their own learning, but we didn't record any of the simulations or scenarios. And it was all volunteer, so it was free. It was EMSC and HRSA sponsored, and so participants were able to get their CME credit and participate for free, which was a huge plus and ended up with a wait list. So it was definitely volunteer, and folks were pretty pleased with it and hoping for future simulation events in the future.
Great, thank you. All right, so I'd like to thank all of our presenters and the teams behind all of these projects for their amazing work that they are doing. We will be hosting the second half of this live Q&A tomorrow. It will start at 10:10 a.m. And we will go through all the rest of the posters then.